Thank you for joining us this morning. We are here on our third session of our cultural responsiveness and mobile crisis teams. And today we are going to be discussing the Black and African American communities. I also want to let you guys know that coming up for session 4, session 5, we have the Latino, Latina, and Latinx discussion. And then for session 5, we have the youth and young adults coming up. So if you haven't yet registered, please make sure that you're getting yourself on those lists so then you have the Zoom attached to your calendar. So make sure you have those on your calendar so you can join us for those last 2 discussions. All right, and this is a presentation for the M-TAC project, which is funded by DHCS and administered by CARS in collaboration with AHP. The views and opinions expressed in this program are those of the speakers and do not necessarily reflect the views of DHCS, CARS, AHP, or the M-TAC project. All material appearing in this presentation, except for copyrighted sources, is in the public domain and may be reproduced or copied without permission from DHCS or the authors. We do appreciate if you cite the source, though, if you are going to use that information. And if you choose to reproduce it, please do not do that for a fee and don't charge people for the information unless you have specific authorization from the M-TAC project. And this presentation is going to be recorded and it will be posted on the M-TAC website at a later date. And we do want to do a California land acknowledgement as well. We acknowledge that this virtual training is taking place throughout the unceded territory of California, home to nearly 200 tribal nations. And as we begin this event, we acknowledge and honor the original inhabitants of our various regions. Land acknowledgement is a critical step towards working with Native communities to secure meaningful partnership and inclusion in the stewardship and protection of their cultural resources and homelands. So let's please take a moment to honor these ancestral grounds that we are collectively gathered upon and support the resilience and strength that Indigenous people have shown worldwide. I am here in the Serrano territory of Southern California. And so just being able to honor the land here and take care of that is really important to me as well. So today we are going to be discussing the cultural responsive crisis care in Black and African American communities. We are thrilled to have with us Tansy McNulty, who is a CEO of 1 Million Madly Motivated Moms, or 1M4. Tansy is a social justice advocate and the founder and CEO of 1 Million Madly Motivated Moms, 1M4, which is a nonprofit organization dedicated to ending police violence in the United States by 2038. Tansy is a thought leader in the fields of police accountability, mental health, and safety alternatives with a focus on public safety transformation and community-based approaches. With a deep understanding of the intersection of social justice, police accountability, and mental health, Tansy is committed to creating positive generational change in the world. She is a leading voice in the fight against police violence, advocating for innovative solutions that are data-proven to increase public safety and decriminalize mental illness. With Tansy's leadership, 1M4 released the first of its kind national directory, The Right Response, to assist community members in locating local response teams trained to provide on-site, care-centered responses to people experiencing mental health emergencies. Since its relaunch in 2024, nearly 4,000 unique visitors have referenced the tool and has been featured in national media outlets such as Good Morning America, Third Hour, Business Insider, Essence Magazine, and Biz Journal. So without further ado, super excited to have you here, Tansy. Tansy McNulty, who is going to be leading us in today's session.
It is an honor to be here. Thank you all for having me. Thank you for sharing space with us. And thank you for literally answering the call. So here are our learning objectives. We're going to walk through this slowly and intentionally. We're going to increase our knowledge in the historical context of crisis response in the Black community and the role of community-led crisis response initiatives. We're going to gain awareness of what policymaking at the federal and state levels are shaping crisis care and how policies are impacting the mental health of Black people. We understand the dual impact of systemic control and healthcare disparities in Black mental health. And then also discuss cultural stigmas and challenges that impact a Black individual's willingness and ability to access care. We're going to learn how to apply culturally responsive de-escalation techniques in the Black community to ensure safer and more effective crisis interventions. And then we're going to explore a directory that we helped compile of community-based crisis response models as alternatives to law enforcement. Our agenda is going to follow pretty much the same pattern as our learning objectives, right? We're going to check every box as we go. We start everything with deep breathing exercises. Then we're going right into the history, followed by policymaking and its impact on your work, and a brief discussion about the demographics of the Black community in California, discuss some stigmas within the Black community, de-escalation techniques for our community specifically, and communities abroad as a whole too. They apply to all, but we have some specific ones for the Black community. And then we're going to discuss the right response. What is the right response for our communities? And then we're going to ask for your help to share the right response, to do what you're already doing and doing well, to help us be better, to help people get the response they need in their time of need. All right, are we ready? Let's go. So before 1 in 4 does anything, we are a mental health and a public safety organization, and we prioritize the wellness of every space that we're in. We honor every space that we're in. And so we want you just to take a few moments to just pause. I don't know if you've just gotten finished responding to some people in the community, if you just left a stressful meeting, if you're headed to a crazy meeting, wild meeting next, or you're going on to your shift next. We don't know where you were before or where you're going after, but what we have is right now. We have this moment right now together. We have a chance to pause. So I would love for you to take just 3 deep, intentional cleansing breaths. And as you exhale, actually give an audible, if you can, not too loud. I know you may have your coworkers around, but just let it out. Release and relax your shoulders. I tend to hold my stress here. Relax your jawline. This T area right here, our frail line, relax all of that and just breathe. Just breathe. Your presence is a literal gift. That's why it's called the present, right? But we want to honor the fact that you said yes to be here. You didn't have to be here, but we honor your presence. We're grateful for your yes, and we're grateful that you're honoring the space here with us today. And so we'll do one box breathing exercise as we're going to inhale 4 counts. We're going to pause for 4 counts, and then we're going to exhale 4 counts, and we're going to pause. Okay? Here we go. We're going to inhale for 4, 2, 3, 4. Pause. 2, 3, 4, and then exhale for 4, 2, 3, 4, and pause. So thank you for doing that for us. Thank you for being present, and we're going to jump right in. So we have our first conversation piece. So about a month ago, I was sitting at a round table with a few Black women, and I had you all on my mind. I was thinking like, what should we share about Black culture collectively? What should we talk about? What should we share? And I asked these women, what would you share? What would you want people to know about us, about our culture, about things that make us a little bit unique? And we're 4 Black women. We look similar, but we have different economic statuses. We come from different regions, different cultures, subcultures are within that. And so I wanted to hear from you all. What comes to mind when you think of Black and African American culture? Oh, I love it. Resilient, rich culture, friendly, powerful, confidence, unity, variety, strong, community, beautiful, passionate, outgoing. I see strength in the chat. It popped up. Excellence, Black excellence. Misunderstood. Maya Angelou. Okay. Okay. Any others? The dance, the movement, dance styles, creative. I love it. Spirited, family. I love it. I love it. And I'm going to say, yeah, to most, to all of this. This is pretty spot on. Yeah, our musicality, yeah, resilient, powerful prayer. the spiritual side. Absolutely. Y'all took actually most of our responses from the conversation with the women. You got most of them. So you'll see a lot of what you put in the chat right here. So again, four Black women around the table talking, conversing about our culture. And these are some of the adjectives that came to mind for us. And as we were calling them out, we were literally shouting them out because we are loud. I was gonna take loud off because some people see loud as, oh gosh, they're loud. Well, for our culture, loud is joy. We get nervous when it's too quiet, please believe. But loud is joy. We're innovative, we're joyful, we're resourceful. The musicality, we have a song for whatever situation you can think of. Loving, communal, humor, warm. We saw resilient pop up a couple different times. Innovative, but we also just invent things. Both sides of that, we're expansive. For whatever we create, we make it bigger. We want to welcome you all into it. We don't constrict, we don't confine, we're not trying to stifle who we are. We're expansive. So thank you for agreeing with and seeing us and already having a great baseline for what our overall culture represents. So our next conversation piece, and this one's going to look a little different. So this one speaks to the need for what is mobile crisis response, right? Some of us use mobile crisis care, some use crisis response, some use the term community response. There are now input from SAMHSA on more guidelines for the language. But in your different communities where you are, what does crisis care, mobile crisis care, on-site crisis care look like? Like who responds? How are they contacted? What's the makeup? Because you meet one community, you've literally met one community. It can look a variety of ways, and we have a number of ways in our directory ourselves. But for you all, what does mobile crisis care look like in your specific community? Again, this is how they are contacted. This is who shows up. This is whatever the makeup of your crisis team is. Can you share that with us so we have an overall understanding of, I saw some of the names of your organizations pop up, saw your registration, so I know kind of some of the makeup, but let us know what you see, what you see in your community for mobile crisis care. A clinician and an advocate, yeah. Sympathy, compassionate. Some of their traits, they're friendly, they're confident, they're going to be there for someone when they don't have someone. De-escalation, they're supportive. They can be social workers and clinicians. I've seen firefighters and clinicians. I've seen medics. I've seen peer support, supportive and unwavering, resourceful. That is Fletch. Voluntary, not compulsing, controlling people, telling them what they have to do. Understanding, empathy, available. They have lived experience. Very nice.
Yeah, and with a lot of our counties, well, our counties are required to like send people out in teams of two. And so that
Mhm.
could be a number of different folks. And so, having
Safe.
the substance abuse counselors. And so for some of the counties, what are the different ways that the calls come in? Do you get them through 988? Sometimes it's
Mhm.
through law enforcement giving you a call. What are some of the different ways that calls come in, or from which entities are calls coming in from?
Can they come in through 211 or 311? Or do you have your own 10 digit, which we have several of those on our directory as well. 911 dispatch, multidisciplinary partnership with law enforcement that provide mental health services. Okay. Community hotline, the crisis hotline, crisis calls through the schools. Very nice. Okay, that's very, very helpful. Thank you for putting the hotline in there too. Collaboration with the police department, hospitals. So we have a good number, a good mix, and a good makeup here. What fears or concerns might a member of the Black community have when engaging with mobile crisis? So we talked about what you think about when you think of Black culture, what you know about our culture. We talked about what the makeup of your response teams are, the ones in your community are. And now we're asking, with what you know about our culture, what you know about the history of the country, what concerns or fears might a member of the Black community have when engaging with mobile crisis response? Yeah, being misunderstood, judged too quickly, labeled, lack of understanding, police brutality, police violence, judgment, microaggressions, bias, stigma, misunderstood, clinical responses, or sometimes involuntary, escalation, stigma, not being heard, fear of being in trouble. versus getting help. Stereotypes, fear of being hurt physically or mentally. Yeah, further harm when you call for help. Lack of resources. Okay, two worlds, different rules. I hear you, Stephen. Discrimination. Okay, this is very helpful. Lack of trust and help not coming. So we're going to jump into some of this, actually a good bit of this, into where these fears and these concerns, where they came from, what they're rooted in, the history of crisis response in the Black community. This is a very brief overview of a very deep history, so bear with us. We'll continue some of this conversation on May 13th when we get into a more conversational format with a center of practice. That'll be May 13th at 10 a.m. Pacific. So yeah, so what are some of the experiences of the Black community throughout history, right? So a lot of our crisis response history, the history is rooted in systemic racism. It's rooted in the control and the restricting of the movement of Black people through enslavement, through Jim Crow, through every other form of harm that has happened in our history. Is over surveilling the monitoring of Black communities where we can't actually fully operate and live holistically in a state of liberation or free, truly free, because we can't be as loud. We can't go to certain communities. We can't do certain things. And then it's come with force. We may call for help or may have to reach out for help. And then we're met with forms of excessive force, particularly for Black and other marginalized groups. So these are just some of the roots of the experiences that we have. And then to go back to speak about how medical and medicine and mental health diagnosis, some of our first diagnoses came from junk science with drapetomania. This individual, Samuel Cartwright, in 1851, came up with this term, which identified and diagnosed enslaved individuals as having a mental illness because they wanted to be free. He felt that the best and only treatment for these individuals was to whip them and for them to be under the subjugation of a ruler or overseer, a master, that their bodies were made differently, smaller brain cells, smaller blood vessels that make them barbarians. This individual put a medical term on his oppressive thinking. And so us now, as we're responding to people, anytime we see something that feels like, why are we treating this group like this? We should always question, always question, always question. He used medical systems to subjugate Black people to slavery. And this terminology stayed on the books until 1914. It was eventually seen as junk science that it was harmful. It was untrue. It was not rooted in literally anything other than his pro-slavery ideology, but it was there until 1914. And then from drapetomania, we go over to excited delirium. Now, this is a term that's been used by law enforcement and medical examiners to say that when someone's agitated or they're just extremely agitated, they're aggressive, something's wrong with them, they have to be constrained. It's an excuse that's used to constrain people. And when they're constrained, instead of saying what their true cause of harm was, their true cause of death, excited delirium. Thankfully, your state of California, as of 2023, has banned the use of this term. And then Colorado followed suit in 2024. But it did a lot of harm and it disproportionately impacted Black people, especially those that were involved in restraint-related deaths. The National Association of Medical Examiners came out and advised against the term. The APA eventually issued an apology and also advised people not to use the term. Then those two states were the two that have, California and Colorado, that actually banned the use. And it took the responsibility away from the officers who did the harm and put it on the individual. It's something that they did that caused them to die because they had this excited delirium. And these two individuals, Elijah McClain and George Floyd, these were the justifications that were used to restrain them in the ways that they were restrained. It was cited as excited delirium. Again, medical terms applied to situations that are rooted in nothing. So what happens when the community, they see these harms, they see these things happening, when the community decides to show up for itself? And so I wanted to highlight two groups that have done some amazing transformative work in crisis response, but it's also in emergency medicine. It's bringing medicine and medical providers out into the community, caring for people from their home to the hospital. And those two organizations are Freedom House out of Pittsburgh, and then the Black Panther Party. Freedom House were some of the true innovators and blueprint for creating the paramedic system, the ambulance system as we see it today. I had the opportunity to speak on a panel with a Freedom House member, and I'm going to share that. I'll share that with you all in the post presentation notes. It was amazing. You have a group of people who decided, hey, we see a problem in our community. We want to answer the call in our community, want to upskill people who may be unhoused or may have been formerly incarcerated to train them to be medics. And they did just that. And they literally wrote the book for how modern medicine or how ambulances serve today. So even though these two organizations are no longer operating, right? They're not operating now, that does not hinder their impact. We're getting the care that we need from our home, from wherever we are in our country, because of the roadmap that these individuals wrote. And both were eventually either could not get the funding or were defunded in one way or another. And then with Freedom House, the city took over the ambulance service, and they did hire some Freedom House members, but eventually they were let go. And so I just wanted to pause and thank them for what they have done for us in the crisis response space, and to highlight the fact that not that long ago we used to put people in the back of police cars to get them from their house to the hospital with no care, right? And now we do. Now because of these people, these individuals, they stepped up and did something that was truly transformative for the industry. Okay. So we were at 1970. We're gonna take a big jump now. Big jump to the 2020 uprisings, right? So in those uprisings, that's when, fueled by the murders of George Floyd, Breonna Taylor, and Ahmaud Arbery, the uprisings enhanced the calls for decentralizing police and investing in community-based alternatives. So we're in the streets, we're saying, hey, we don't need police for every single call. Can we invest in other types of responses? And that's where programs like Cahoots was already going on at years before the uprisings, but during that time, their exposure was elevated. A lot of people were on Cahoots, they were going to North Carolina's Tar Heel area, a response team, to figure out like how can we recreate these type of response models across the country. It got so busy at Cahoots, we had to even create an online resource to try to show people how to create their own teams, in addition to having people come on site to tour their facilities. Sadly, as of this month, Cahoots won't be operating in Eugene anymore. So remember the history from the other slide. If we don't study our history, we're doomed to repeat it. But there are other teams have been created in different spots that are based on their modeling. During those same uprisings, we were asking for community violence intervention programs, non-police traffic enforcement. If police don't have to be there, let's let them stop and let them focus on things that are serious crimes, things that they are more tooled and skilled to respond to, while professionals deal with mental health emergencies, substance use disorders, and we even have peers to help with that as well. It's really getting we're asking for the right resources at the right time. So we're not going to use a hammer to fix a mirror. We're going to use the right tools at the right time. Same thing with this. The impacts of creating these new alternative response teams are still unfolding and standards are being established. We'll share with you also, SAMHSA's guidelines on mobile crisis response that are coming out, that are happening now. And they even have an open call for public comment. So I would encourage you all to give public comment if and when you can from your vantage point. It does help and it does matter. So after those uprisings, we had policymakers say, okay, we hear you. We hear you. We're going to do something. We're going to try our best to help both at the federal and the state levels. So federal and state legislative policies that are impacting crisis response. Of course, we have fall 2020, the signing of 98 suicide and crisis lifeline mandate. It was set to go live and it went live July 15th. And it was created to become a 3-digit number, easy to remember number for suicide, to replace the suicide prevention hotline. Remember, the suicide prevention hotline had a long name, a long number. Now you have 3 digits. And since its initial idea was to just replace that, but we as the community and as you all have expanded that quite a bit, where it's now a full crisis care continuum from not just someone to call. So there are 3 main components of this continuum: is someone to call, someone to come, and a safe place to go. So that's what this graph is showing you that came from you all, some of the state of California Health and Human Services. And the purpose of mainly this talk that we have is the middle portion, the someone to come, which is also the focus of our organizations. Who's going to show up in the time of need? Who can I trust to come care for me and not try to harm me or not add additional harm? So expanded it from just someone to call to reduce police involvement in emergency department reliance. That was 2020. That was signed October 2020. 2021, we had ARPA, the American Rescue Plan, was signed into law in 21. It was to lessen the impact of COVID-19, because during that time, we had a significant impact on most people's mental health, was negatively impacted during that. And so a significant portion of ARPA was designated to fund local mental health crisis programs, community health block grants, health services block grants, community-based funding for local behavioral health needs, and to support the public health workforce. And then it also used a portion of that for those states that would like to use a portion of that for Medicaid to cover mobile crisis services through the FMAP process, FMAP percentages, excuse me. 2023, AB 988. That's the Miles Hall legislation. It was named after Miles Hall, who was killed by police in 2019 during a mental health crisis. And this helped establish and fund 988 services in the state of California. It was driven and advocated for and pushed for by his family. Some of their picture there. His family, Ton and Alicia, his dad as well, and supported by legislators. This has provided a non-police response for mental health emergencies. The Hall family took it a step further in partnering with the A3 Crisis Center at Contra Costa County. That's anyone, anywhere, anytime, no wrong door for getting the response that you need to a mental health emergency, all in the honor of Miles Hall. And I actually carry this is Miles on his bike. I carry this with me in my briefcase. It's usually on my desk somewhere, and then I wear the ribbon to remember Miles, to honor the work that his family has done, to always stand with them. This is it's the green and the black, green to represent mental health, the black to represent social justice. So I wanted to just show what they're doing in Contra Costa County. They're very accessible, very easy to reach if any of your programs want to converse and talk with them. So let's talk about the Black demographic and the Black population and where the population is concentrated there in California. So the Black population has been declining over the last several years. Currently, it's at 5.6% there in California per the 2020 census. Most Black people are concentrated in your metropolitan areas, the great majority, both in LA and in the Bay Area, with some now starting to migrate outside of the state due to cost of living, right? You all know what it costs to live where you live, either migrating out of the state or moving to more suburban areas. Some of the impacts to the Black population have to do with us having the lowest household income in the state and the cost of living, and then redlining, reducing the home ownership, and having an impact on reducing the home ownership rates. Exiting the state at the rate, Black people are second to non-Hispanic white people, as in leaving the state altogether. There is a booming African migrant immigrant population there in California, particularly those who are Ethiopian, Nigerian, South African, and Eritrean. And there are also Caribbean immigrants there as well. I could not find their numbers, but if you have their numbers for how many Caribbean Black folks there are in California, please let me know. I would love to add that to this slide. So now we'll talk about some of the health disparities in the Black communities. We have some of the higher uninsured rates. And then due to that, like there's an increased risk of, just lacking access to care because of the cost that comes with it. We have to be able to account for that, budget for that if we don't have insurance, or if entities don't take the insurance that we have. We report lower health reported status, shorter life expectancy relative to our white counterparts. White counterparts are at about 77 years life expectancies. Black people are 5 years less at 72, almost 73. And then lack of quality healthcare inside of our local communities. And then the birth rates were 2 times, Black infants are 2 times more likely to die, infant mortality rate, and 3 times more likely for birthing Black people to die during maternal and health-related pregnancy deaths due to the health disparities in this country. Some of that, we talked about some of the history of us with, the medical system, but it has to do with, not believing us when we go to the doctor, not being listened to, not having the access, not having the money. The amount of time that it takes just to find the care, the quality care and care that's representative of who we are and care that listens to us, it is a struggle. It is getting better, but it is still a struggle. And these are some of the factors that impact the mental wellness and the mental health of the Black community. We still have stigma, fear, and shame associated with anything dealing with the mind in our communities. There's a barrier to the access and to finding quality care, both on the mental health care side and the physical care side. And then racism and trauma and microaggression and structural racism very much impacts your body and your mind. I highly recommend the book Black Fatigue that talks about weathering, what it's like to just the weathering of those things on our physical health and our mental health, and then having clinicians that are culturally competent, understand racial and cultural biases, which is why you all are here today. It's right to have an understanding why you attended the other sessions to understand community that you're responding to, and we appreciate that. We appreciate you making the time, so we know you did not have to be here. And then the equal access, and then representative care. Does the clinician look like me, understand me, um, care about me? Care can come through in a lot of ways. And our friends at the American Foundation for Suicide Prevention provided this graphic, which is the let's save lives, which is let's listen, empathy, show trust, and support. This is both intra community inside the Black community and for those who are caring for those outside the community. So remember that acronym to always listen, be empathetic, build the trust, and support the person that you're responding to. Now, these are some cultural stigmas that are within the community. Now, we talked to this graph also came from our friends at the American Foundation for Suicide Prevention. One of the one of the biggest stigmas and inaccurate information that I have heard in a while is suicide is a white folk problem. That's a quote. It's a white folk problem. And that is incorrect. It is very harmful to believe that. It's very harmful to say it, but even more harmful to believe it. It is impacting the Black community. You can look at this graph came directly from the AFSP, their site. It actually has more races. I just highlighted Black women, Black men, but you can look at just after 2018 and the spike for Black men in 2020. The line for Black women looks like, oh, they're doing pretty well. Um, but no, it's impacting. Let me rephrase that. Death by suicide, we do have lower rates than our white counterparts, but it is increasing at an alarming rate and reaching the attention of researchers. Let me go to the next slide so you can see what I'm talking about. So for the Black community, suicide is the third leading cause of death for African Americans, particularly our youth. That's 15 to 24. And then our youth, their rate of death by suicide is increasing faster than any other racial and ethnic group right now as of 2022. And Black men, they're dying by suicide at a rate of 4 times that of Black women. So something is happening, but I am glad that we are talking about it more than we have in the past. That's why you see the barbershop talks. You see some of your athletes, your public figures coming out to speak about it and being more visible about it because the numbers are heading in the wrong direction. And we're doing our best to stop that. And you all will probably get calls like this that may have to do with someone who is having suicidal ideations. But we have got to shine a light on this issue and stop saying this is white folks' problem. No, this is the problem of a lot of communities, and we are one of them. Mental illness. Mental illness is a still a very taboo issue inside of the Black community. We have historical mistrust of the healthcare system, but then we have this idea or this expectation for the strong person. We have to be strong. We have to be strong for our community, for our families, for everybody else. And that can hurt us. That can hurt us to the point where we're not speaking about what we actually feel. There's a fear of being judged, fear of being rejected. And then there are some economic and systemic barriers to that too. Like if I do seek out a therapist, when are they open? Oh, they're only open 8 to 5. I can't get off work. Do they have weekend hours? I can't get to where they are, or they don't take my insurance. Personally, I've had a difficult time finding a clinician for my children that can take our insurance, that's close to us, that the child actually can, connect with. It can, it, it can be difficult. And then there's lack of representation in the field. And then we have our spiritual and religious influences that may or may not be helpful when it comes to mental health. Saying things like, pray it away, pray your mental illness away. That's not helpful. Or the fact that you have, oh, they'll say that you're having this issue with mental health, or you have a mental illness because you don't have enough faith. Get your faith higher, increase your faith. Like Black people, we are some of the most religious and spiritually rooted people in the country. According to Pew Research, we believe in a higher power at a rate of 97%. The majority of Black people in this country are Christian. However, for those that are not, they even believe that there's some type of a higher power. And we're rooted in our religion, right? So when you have faith leaders who may say things like these things, just pray it away. Oh, you need to increase your faith. It is extremely, extremely harmful. Extremely. And then there have been some that have even called therapy and therapeutic practices demonic. And that doesn't help your congregation members, your audience, your followers, whoever you're overseeing, you're helping spiritually. That's not helpful for them at all. And one thing that you may see as clinicians, you may see religious persecution displayed in the illness. I'm an individual who has multiple people in my family who have serious mental illness. They have SMI. And so in two different situations with two different family members, when both have bipolar 1, whenever they were elevated, they had a mental health crisis. One thought that she was God or Jesus. The other one believed that they were the opposite. They were the enemy of the devil. And you will see that flare up inside of the mental illness. But please respect, always respect the religious beliefs, respect the religious fervor, because it's deeply rooted inside of us. Just as you're speaking to people, you can be a believer and go to therapy. You can be a believer and take medication if you choose to. There is nothing wrong with this. But I wanted to call this out. There's not a scripture. I'm sorry. I'm getting churchy on y'all. There's a quote by James Baldwin who says, I'm an American, therefore I have the right to criticize America, right? I love America. That's why I criticize at the level that I do. And I am someone who comes from a religious background. That's why I criticize faith leaders like I do. You have to be responsible when you speak before people and when you're telling them things like pray it away. We cannot do that, especially right now in our current.
And just to have a comment, Stefan made that, we can't be strong all the time. We are human and the pressure feels greater in our community. So absolutely, just validating everything that you spoke on, Tansy.
I appreciate that, Stefan. Especially the human side of it, the humanity side of it. Um, yeah, I really, really appreciate that. We're going to talk about the human side of that in just a moment as well. So let's get over to some strategies. Any other questions or any other comments? I feel like I've been talking. This is a conversation, guys. This is a conversation.
Yeah, there's another comment in the chat from Christine. Absolutely, faith and mental health treatment can live together. So
Absolutely. Without a question. Without a question. Thank you for that. So some key de-escalation strategies inside of the Black community. I think Stephen just said that about being human. So we're going to lead with humanity of the community person, community member, community individual. Lead with their humanity. The reason I thought it was so important to start with the history first, because I need you to understand that when you come to someone's home, you're meeting that history. That's why they may respond to you like they do, why they may engage you, because they know what they've seen in the past, right? So understand the history of first response. Understand that you're bringing something different, that you're arriving in from a position of care and not punishment. If and when at all possible, avoid law enforcement. If they are not needed, please don't invite into the situation, because once you do, it is now a weapons involved. It's there. Once it's there, right? So come from a position of care and not punishment. Make sure you're listening to understand and not listening to respond. The more curious you are, the more you take your time, don't rush the interaction, the better. Be very curious to understand what is happening. What am I responding to? What are the dynamics here? Were the potential triggers? I know that I've seen some dashboards where we're measuring like how long people are on calls and how long they're on the phone, or then how long they're physically at the location. If at any point leadership is asking you to rush that, can you get that? Can you get more in? I asked you to question them. And I ask you to question them and just say, is this the right metric? Are we working toward the right metric for the community member? Or are we just trying to get people, see more people? Use time to your advantage. Don't rush the interaction. Never assume, never assert, ask. Just ask. Ask the question. And your goal is not to control what they do. Your goal is to guide that person to the right solution for them. Autonomy is so important. The slides we spoke about in the history, like the controlling the movement, that's not what this is. That's not what you're here for. You're here to provide a different type of response. You allowing and guiding them to the response that works for them is so valuable. It is so important for them to have the autonomy, them to have the decision making in their own court. Allow physical space, allow space. Don't walk up on anybody, right? They don't know you. You just popped out of the car 2 minutes ago. Would you want someone to be in your, no, right? Allow physical space between yourself and the community member. Angle a little bit, leave it a little bit open where you're not as, in their face as you might have been. Always show deference to older community members. Manners matter. It matters a lot. Not turning your back on someone. I know you wouldn't with the community member you're serving, but even the mother, the grandmother, Mr., Miss, formal titles. Be respectful to our elders, because we respect our elders. They are very important to us. So when we see disrespect from them, that it automatically you put a wall up. Like, whoa, who are you? Like, respect the elders, manners matter. Be aware of your implicit bias. Let me do the full definition. So we're talking about the same type of bias. Implicit bias, also known as implicit prejudice. And implicit attitude is a negative attitude of which one is not consciously aware against a specific social group. How do you know what you don't know, right? Check yourself. Know that your call, that interaction is unique. This interaction between you at this moment in time has never happened before, and it will never happen again, just like this. Treat everyone, every situation like that, like it's unique. You cannot group people together. Um, Passion is not aggression, right? We talked about being loud, expressive. You may hear a curse word or two or seven. It's fine. It's a word. It's their descriptors. It may not make you feel comfortable, warm, and fuzzy, but they are words. And people may use that language to explain. They're being expressive. They have a heightened voice. Heightened voice is not different from talking. It's just a different level, right? It's just a different level. And just like some Black people and people in general talk with their hands like I do. Don't be alarmed. They're just explaining to you what happened. It's an emergency. It's something they want to get out. They're excited, and it's going to come out that way. And I know I've used Black culture and community several times in this presentation, but we are not a monolith. We are not the same. We have subcultures within the Black culture. So African American is different from Afro Latina, which is different from Nigerian, which in Nigeria you have Igbo and Yoruba, and then there's another tribe I'm forgetting, forgive me. But there's cultures inside the Black community. So everyone is not the exact same. We have similarities overall, but we're not the same. And if you don't know, just ask. Genuinely be curious. Just ask the question, like, what culture or cultural experience do you most closely identify with? As long as you're authentic, you will get an answer. They'll tell you. We don't expect you to know every subset.
And Dory in the chat just brought up as well, having a trauma-informed approach helps so much. And
Mm,
that starts with how we phrase things. Not saying what's wrong with you, but can you tell
mm,
me what happened? Like what's the situation about? So it's not identifying the person as the problem.
perfect. Yes. Another book I read that shifted the way I operate. I think I read it maybe 4 or 5 years ago, was on What Happened to You. Dr. Perry and Oprah was I think Dr. Perry wrote it, but Oprah's on there as as an author too. But what happened to you? You make sure we're asking the right question, not what you're doing or why'd you do that? What happened? Well, thank you for sharing. Yeah, so additional de-escalation strategies, make sure that we're listening to our community members, family members, and loved ones, understand that they know and they can explain to you what's happening and what's going on. They're the experts of their lived experience. And even though you have the professional designations, it does not override the individual and their community members, their family members. They can help you. They will be an advocate for that individual in their time of need. Understand that the matriarch in the family may be the leader. So don't assume that granddaddy over here is the one who's going to have the last say, because in some families, and mine included, it's Medea, Mother Dear. That's who's going to have the last say. It's Big Mama. Like she makes the say. So value that, value her opinion as you're saying, Mrs. So and so, as you're showing that deference to her, and then recognize that we're very interconnected. We're very communal people. So my cousin, my family, my sister, they're not all biologically related to me. Most of them are not. I have many, many cousins. Let me put it out there, but that does not make them less related to me. They have the stature in my life as my family. So notice that, extend that team, make it a team effort when you're on site, and they will help. They will be your community, your team, that individual's team to help. So it's not just people who are there, who are their direct relatives. All right, so we're going to go into some I haven't heard your voices yet. I am interested in meeting each of you. I see the number, I see little boxes, but I want to get to know you. So we're going to do some scenarios here. We're going to work through some things together. And I want to thank some of my counterparts for providing these scenarios to me. We'll go over who they are in just a moment. But for our first scenario, being at 101, I'm going to read it verbatim and I'm going to give you the questions, okay? You're dispatched to the home of Regina, the mother of 18-year-old Jamal. Jamal has been diagnosed with schizophrenia. He has been compliant with his medications for many months and has a good relationship with his psychiatrist. However, recently Jamal has stopped taking his medication and is acting aggressively towards Regina. This aggressive, as a side note, this aggressive adjective came from Regina. She said this, right, when she called, okay? She called crisis response as a last resort, stating, either get him to take his medication or remove him from the home. Okay, we got that? Here are our questions. How can you, or how would you engage Jamal in a way that centers his humanity and autonomy? What questions could you ask to better understand Jamal and reduce his potential concerns for his safety? How can you engage Regina in assisting with the call? So this scenario came from our friends at the Los Angeles Unarmed Model of Crisis Response. Thank you. I can see faces. Yes. Hi. I can see you now. So now we're gonna turn it over to you all. How can you engage Jamal in a way that centers his humanity and autonomy? What questions could you ask to better understand Jamal and reduce his potential concerns for his safety? And how can you engage Regina in assisting with the call? And then Stephen jumped right in. I would ask Jamal, how is he doing? Ask Jamal, what's going on? How you doing? Using LEAP to understand and build rapport with Jamal. Cynthia, will you give me the LEAP acronym, the one that you're referring to? And Stephanie, how did you feel when you were taking your medications? That's a good question. Letitia, my approach would be directly to Regina as the peer support, asking what does the aggression look like? Since remember, Regina used that descriptor, not the crisis responder, right? And has it affected her ability to be safe around her son? So go in calm, Christine, go in calm, let Jamal know that you're here to help. And Regina, try to have a better understanding and patience. Thank you. Thank you, Cynthia. Listen, empathize, agree, partner, the LEAP strategy. Dr. Ruby, I might have Regina and Jamal be separated so she can speak openly about her concerns without Jamal hearing it. and potentially getting upset if the report feels offensive to him. Cherish, introduce myself in my role and that I'm here to support. And whatever you ask Jamal, don't be shocked on what his answer would be. Compliment Jamal and find something positive about it. Okay. From Dory, explain that I spoke to his mother. However, I would ask if he would like to ask me any questions before we go any further. Because it's a conversation, right? Like we're not just talking at Jamal, at Regina. We're listening, right? You have questions for me. You don't know me. You just met me a few minutes ago, right?
Yeah, and I think one of the big things is being curious too. One of the things that I noticed is he was fine with his meds. For a long time, he was fine. So something changed, something happened. So that's what I would get curious about.
And I don't know if you all caught, I kind of read it kind of quickly. He has a good working relationship, a good relationship with his psychiatrist. So tapping that individual in as a community, as a part of that team we're talking about, right? This is not a one-on-one. This is a us to help you. This is an us thing, not a you thing, right? Make sure Jamal knows that I'm there for him and want to know what he needs and his end of the story. Yeah,
Yeah, finding out
this
what
is
his
phenomenal.
perspective of everything is, and then what's mom's perspective too, just getting both sides of the story.
All right. Ask, do you know why we're called out today? Start the conversation by asking what was the reason he stopped taking his meds. Just ask him, yeah. Is he having side effects? That's a good question. Has he talked to his doctor, his psychiatrist that he trusts about this? And then, oh, Aisha, my coworker, said to listen to understand and not respond, right?
Exactly, exactly.
Mhm.
So it's really important to figure out what life looks like through their lens, through their shoes. Everyone who we're in engaging with, what's their experience like?
Yes, he might be likely feeling scared or misunderstood. The calmer, more open we stay, the better chance we have of helping him feel safe. Recognize that he is an adult and he has a right to privacy. This is very fair,
That's a
very
really,
fair.
really good point. Maybe now that he's 18, maybe he has a different viewpoint on how his mom should or shouldn't be involved in his medical care. That's a really,
Mhm.
really good point to be curious about and see.
That is the truth. And I'm gonna get through these and I'll tell you what happened on this call here shortly. Remind them that we're here for him. I think one of the most important things is to start by asking how both Jamal and his mother are doing. Yeah. Take time to debrief with the mom so she feels supported. Ask Jamal if there are any current stressors for him. Like what, because he was doing it before.
Yeah.
Something shifted, right? Let him lead the conversation before introducing, this is what your mama told me. This is what your mama said, right? Let him set what we're doing today. Even though mother may have been the one who reached out. Okay. Well, this particular team did much of what you all said. They were extra curious. They took their time. They did one talked with the mother, one talked with Jamal, and they found out that taking the pill, he was feeling it was stigmatized. He was feeling otherized. He felt like I have to take this pill every single day. This is going to go on forever. And then what they did was they found out that the psychiatrist was a friend, someone he respected. So we gave that information to you up front to kind of set the stage. That team had to kind of pull and ask that to figure out that relationship. And then they let him know that, hey, I know you're taking, you were taking this pill before. You don't like taking it, right? It feels like it's stigmatized. You don't want to feel like you're doing have to do something every day. Did you know that we have the option of doing a long acting injectable if you want to, if you choose to? It's similar to what you're doing now, but it's one injectable that releases small doses over the course of a month. He did not know that was an option. His mother didn't know that that was an option. And when he heard that, it felt less heavy. And so that is the option that they actually move forward with in this example. What I also didn't share in the scenario was the fact that I don't know if the last thing the mom said, come get him or he has to be removed, and that it was a last resort phone call because this mother actually lost a friend during a mental health crisis to police. They were killed by police during a mental health crisis. So for her to call, it was absolutely the last result. And she called 911 to get to this team. So she wasn't sure who was coming, I don't believe she was sure. You can correct me if I'm wrong, if any of our LA unarmed people on the call, but I don't believe she knew who was going to show up, but she was very glad that the unarmed team did, and they came to a solution that worked for that family. So all your comments, all your questions, spot on. And I'm actually learning quite a bit, right, from you all. And so I thank you guys for participating. And yeah, super scary to make that call, especially knowing the history that she had lost someone in a very similar situation. So understanding the history too. So when you're talking to the mom, she probably would have she offered up that information in that solo conversation. Okay, so we're gonna pop into one more scenario and we'll pop back out and have a conversation. So give us one moment to get reset. And thank you to the Los Angeles Unarmed Model of Crisis Response Team again. Thank you for sharing with us. Okay, number two, you're dispatched to the home of Keith and Carla, who also live with Carla's father, Mr. Earl or Papa. Their 12-year-old son, Malcolm, has a history of medicalization. That's medicinal treatment for non-medical issues. Recent triggers at school include bullying for his consistent redirection in the classroom, which have caused him to emotionally withdraw. As a result of school interactions, he is receiving consequences at home. He is refusing now to go to school, and his parents called for assistance from a professional. Keith and Carla expressed they did not want to involve law enforcement for fear that he will be perceived as older than his actual age. And here are the questions for our discussion. How would you approach Malcolm? What questions could you ask to better understand Malcolm's history with the healthcare system and reduce his potential concerns about the future? And given some of the triggers came from inside the home, how could you show respect to the parents while also acknowledging Malcolm's triggers? What resources could be shared with Malcolm and his parents for continuous support? So again, I will turn it over. We're going to pop back out and have a little bit of a conversation. Y'all had me talking to myself. Me and Aaron just hanging out. We talked. We've already talked. We want to get to Again, how would you approach Malcolm? What questions could you ask to better understand his history with the healthcare system and reduce his potential concerns for his future? Given some of the triggers are inside the home, how could you show respect to the parents while also acknowledging his triggers? And then what resources could be shared with Malcolm and his parents? Continuous support.
The vignette states that that Malcolm could be perceived as being older than he really is. He's a 12-year-old kid. And so oftentimes when people are looking older than their age, a lot of times the outside world treats them like they may be 15 or 16 or 17. And so how would you ensure that you continue to address him as a 12-year-old and not as a 16 or 17-year-old when you're meeting with him?
Yeah, Patricia jumped in. What support system is he receiving now? Does he have any services that he's receiving now? Have you had to see a lot of doctors or therapists growing up? This is going to Malcolm and probably also to his parents too to get some background.
Yeah.
Yeah.
And just going back to the age thing too, sometimes when we see somebody as being older, we expect them to act more mature. We expect them to act like a 15 or 16-year-old and not like a 12-year-old. So just being able to curb what your expectations are based on what someone's presence, what their physical appearance looks like. Just making sure that we're like, and that this could be happening at school too. If he looks older, his teachers could be thinking that he should be acting more mature or, whatever else may be going on.
Yeah, asking Malcolm what the problem is, let him explain, do the same for the parents. Parents seem to be trying to find a solution. They did reach out, they're looking for something, right? When did the bullying start? Stephanie, how does it make you feel? Have you informed your teachers and the staff at the school about the bullying? Asking parents about the member history, ADD or ADHD. Is there medication that's being taken for such of the I'm sorry, for these such instances and provide some resources for developmental and coping skills pertaining to that child's age, right? Think of age-related things like Disney and games to kind of relate to him a little bit, and then find out what he actually likes to get him to open up to build some trust with him. Recognizing the development level of a person is so important, Infantilizing is never okay, or expecting a person to behave older than their actual age. He has rights.
What do you think we can do to support the relationship between Malcolm and his parents? Because that's also one of the triggers for him. So at school, he's being bullied, he's being redirected a lot, and then he comes home and there's consequences. As the parents, if you could talk to Malcolm alone, see what the triggers are at home, absolutely. So home may not feel like a super safe place with how his parents are disciplining or consequencing based on what's going on at school. What other ideas do you have on how to engage with his family? Or what resources and support is there? What might be some of the next steps? A peer group, yeah. The school setting, a place for Malcolm to chat with kids his age that would be appropriate. And that could go in with what somebody else said, Patricia, about games and gaming. You know, maybe an outlet for him um, to have a community like through his gaming system. I know my kids do that all the time. So, what other supports are available to him and the family? Is there a place of a family member who he feels safe? I think that's a great question to ask. Knowing
Remember that
how,
in this particular example, we had the grandfather, Papa is there. So maybe that's a safe, another safe male figure who can have some presence there in his life. Ask about diet and sleeping habits and hobbies. I don't know, Dr. Rupi, this example came from Dr. Rupi. She's on here. If you want to share anything about that experience, just briefly, please come off mute and share. But we thank you for providing the scenario, providing some of your experience. But go ahead.
Thank you so much. This is great. I think one thing that came to mind is just the child has been medicalized, and even our language of treatment and care is medicalizing. And so I think a lot of times, especially with Black children, knowing that there's a tendency towards punishment and control in school, in community, in mental health care, child mental health care, and that parents also sometimes default to that out of a kind of an instinctual drive for safety, given the risks that come up, if a Black child is aggressive or perceived as aggressive or out of control. And so I think what jumps to mind for me with this child is like protection and play. And I sometimes come at these things a little sideways, really trying to engage with a child as a child or as a young person who needs to play and be protected, maybe before the clinical side starts to come in.
Thank you for that, Dr. Ruby. We appreciate that and appreciate you. We'll go back into our slides here shortly, but then Letitia also said, is there involvement with the community like the church or a youth program? That's where I found most of my friends, honestly. Found them inside the church, inside the community center. That's where they were. So thank you for sharing that. So yeah, we're gonna thank Dr. Rupi again for providing this scenario. Thank you so much. And you all can find her at Rupi Legha MD across social media platforms. She is an amazing, amazing resource. Okay, so what is the right response for Black communities? Is there a right response, right? So it's person-centered, it's culturally responsive care. It's understanding that once you come to our home, you're bringing history to our literal doorstep. And you're bringing kind of two, because when you show up, they're thinking law enforcement first, like, who's this coming to my house? And then they're also thinking healthcare, and neither have been overly been helpful all the time to our community. So recognize that, acknowledge that, and understand it. And Black people are human. We've said it a couple different times throughout this, but start with humanity of the person. And these hashtags that you see that are popping up, that you see happen, for us, it's not what happened to them. Look what happened to that person, those, them. It is what's happening to us. So I thought it was important to highlight some of the faces of mental health, people who were harmed during mental health episodes and mental health emergencies. Miles Hall, of course, we talked about, Ryan Gaynor out in California, Daniel Prude in New York, Brianna Grier in Georgia, and then Walter Wallace in Philadelphia. And this is just to name a few, right? So when I see their faces, when I hear their stories, and you may not know some of them, but just jot their name down. You'll have the presentation after the close, a couple days after the close of this session, and just read about them. and see and think to yourself, like, how could this have gone differently if they had a different response or more right response? And for our organization, we created a director to address this very issue, and we called it the right response. It was to be a statement and a question like, we know the right response is not law enforcement for health-centered emergencies. We know that. But what is? We know it's many of you, right? You're responding to the community, to our needs in the community. And so we have put together this directory. It's over 250 response teams across the country, including some of yours are on our guide as well. And it gives people a one-stop shop to find a response team near them if they are available. So 98 and the warm lines, the hotlines are great resources. They are absolutely great resources. But the difference for our resource, it is specifically for people who can come to you. We are squarely in the middle of someone to call. And you all can help us by, there's a survey, we have a partnership with Georgetown Law. Our organization has a part-time with Georgetown, has a partnership with Georgetown Law to improve the right response, to make it more user-friendly for community members, useful for stakeholders and legislators who want to create more response teams, and to give media, those who are putting the narratives out there, a space to find research, find stories. We're adding in stories and visuals of response teams from the perspective of community members. That will be added. We have our first one that will launch next month, so watch out for us. We have a mother-daughter story out of Minneapolis that we're going to be promoting here shortly. But we're just looking for input on the right response, how to make it better, how to make sure we have your teams on it as well. We want everyone, no matter where they are, to be able to find their location and find a response team right where they are. So help us, that's my one ask of this presentation, help us share the right response and increase access across the country. This is how you can contact 1 in 4. I'm Tansy, the founder of the organization. We're a public safety and mental health organization working to end police violence. We focus on prevention, not just reactive. We're on the front end going upstream to find out why they're falling in the river, right? We want to stop the harm from happening in the first place. And all of our ideas come from the mind of Black maternal figures. And we're willing to work with and partner with anyone who wants to create safer and more just in a more just world. That's our email address. That's our social media at We Are 1 in 4 and our website.
I think the organization that you have developed and having the right response database, I've gone on there, it's amazing. And so I think it's definitely something that each of the counties in California, through your process can be added to that database as well. So can you share how maybe some of our mobile crisis teams can be added to that database, if there's a form they have to fill out, if there's a secret shopper phone call that needs to happen?
Yeah, not 3
Yeah,
times. No, so we have a form on the right response directory. You see I think it's a button on each tile. I think, correct me if I'm wrong. Ebony, our ops lead is there, but there's a button that will say, add a new response team, or there's an option too that if we have incorrect information on your response team to let us know about that. You fill out the form. We will call you and contact you. We want to make sure that you have a real phone number that's operational. You'll be amazed by how many people we call that did not answer the phone. And that's like step number 1. Like, you have to answer the phone. Like, so we're going to call you, right? You have to answer the phone. And we have a list of questions like, what's your interaction with law enforcement? Do you have to have insurance? What's the makeup of your team? And we provide that inside the directory so people know what to expect when they call. So they're not just kind of calling out of the blue. And we even recommend that people save. I live in Virginia, right? I want to save the response teams that are in my area in case I need their help, right? Likewise, if you live in California, wherever you are, get familiar with the response team in your area. We put their administrative phone numbers on there as well as their crisis phone numbers. So administrative numbers, you can call and say, hey, I have a son who's, bipolar. What's your process when you respond? So that you get used to talking to individuals, right? So yeah, it's not a hard process, but we do have a process and we want you to answer the phone. We have to be, we believe in accountability for ourselves. Are we doing what we need to do to make sure people get the right response? So we're gonna have to call you first before we put you on the directory. But it's a really easy process.
And I think, one of the big things is, with the development of the mobile crisis teams in California, it was a requirement that teams are not co-located with law enforcement, or they're not co-responding with law enforcement, because with a lot of what you said, it's absolutely true. Like law enforcement, they don't need to be involved in mental health calls. And so if we're able to participate and work with the individual in a safe way, then we don't need to add that weapon, as you said, into these very fragile situations. And so being able to be person-centered and connecting with someone, spending all the time that you need to engage with the individual, to engage with the family, to be able to get them linked up to appropriate and safe community resources that would support them. That's a whole vision of the California crisis response model. And then I think also recognizing that, coming from a mobile crisis response team, there are times when those calls come in where safety may be a issue, where it may not be safe for our teams to go out and respond to the field based on what's going on, at the home or at the site where the individual is. So it's also informing the family. If you
No.
want us out, we may have to involve law enforcement. Do you want that? And letting them know, and it's their decision. Letting
That's
them
part of their autonomy.
know.
Yeah,
Mhm.
it's them. Like you're not controlling the information, you're not withholding information. You let them know up front. This is what it is, and let them make the decision going forward.
Absolutely.
And for John's comment, they are in very specific situations.
Mhm.
Not all mental health calls should have a law enforcement response, but you are correct. They are a part of the care continuum and the crisis continuum.
Yeah, and I know from the community that I came from, really being able to spend the time with the individual is so important. And our law enforcement partners may have a whole line of calls that they have to respond to. So if we're able to jump in and help out and support and be with the person, our law enforcement partners can go on to the next call. And so it's not holding them somewhere where the safety security issue is not needed. So it's important at times, absolutely, to involve law enforcement, and also ensuring that our law enforcement are trained on mental health too, so they're able to recognize and respond to the different crises that come up.
I just wanted to thank them one more time for actually being here, because you did not like have to be here. You chose to be here. And that holds so much value in my heart, in the heart of my entire team. And literally, thank you for answering the call. You have my information, you have our information. Please reach out. We would love to meet you, love to talk to you. And I'll let Erin close us out.
Yeah, thank you so much for being here with your expertise. Greatly appreciated. I think knowing the dynamics of the Black and African American community is super important for not only us as mobile crisis, but as therapists, as community health workers, as peers. And also, if there's any additional support that we as the M-TAC project team can help you out with in your community, in your crisis teams, please reach out. We are happy to do site visits, to visit your crisis team wherever you're located at, and put eyes on, see what's going on, see how we can support in sustainability measures for your crisis team, in outreach efforts. Any way that we're able to support with the M-TAC team, we are here for it. So you could go ahead and fill out the TA request, and we will do everything that we can to support your ongoing sustainability measures for your mobile crisis teams. All right, thank you so much, everyone. I'm grateful for the work that you do. I'm grateful for the lives that you save. I'm grateful for who you are in the community, and thank you for being here, and thank you for being open and willing to learn more about this population.